Welcome to the deep dive. Today we're tackling a really complex but vital topic, the kidneys. We'll be using Chapter 33 from Porth's Pathophysiology, Disorders of Renal Function, as our guide. Our goal here is pretty straightforward. Break down the key mechanisms, the clinical signs you'll see, and, well, the implications of major kidney problems. We want to give you a solid handle on renal pathology.
And it's so important because, honestly, kidney issues are incredibly common. Just looking at the U.S. numbers, you've got something like 30 million people with chronic kidney disease. And the kicker, most of them have no idea.
Wow, 30 million.
Yeah. And then think about the acute side. Over 2 million ER visits every year just for kidney stones, plus another 7 million office visits for UTIs.
Yeah.
It really touches almost every area of medicine.
That really puts it into perspective.
Well,
Okay, so let's dive in. The chapter kind of gives us a framework, right? 6 main areas.
exactly. We'll look at congenital and inherited disorders first. Then obstructions blocking urine flow. After that, infections. Then glomerular problems, the filters themselves. And finally, we'll cover issues in the tubules and interstitium and wrap up with malignant tumors.
Got it. So starting at the beginning, development.
Right. Embryology. It's fascinating because fetal urine production starts pretty early, around week 13, and that urine actually makes up most of the amniotic fluid. So if you see a case with oligohydramnios, basically, too little amniotic fluid, that's a big warning sign. It strongly suggests the fetal kidneys aren't working properly or there's a major blockage.
Okay, so problems right from the start. And there are specific terms for when development goes wrong.
Yes. Three key ones. First is agenesis. That means the kidney just fails to develop at all. Bilateral, both kidneys failing is, thankfully, very rare and incompatible with life outside the womb. But unilateral agenesis, just one kidney missing, happens more often, maybe 1 in 1,000 births. And usually, the other kidney gets bigger hypertrophies to pick up the slack.
It compensates. Okay, what are the other two terms?
Then there's hypoplasia. The kidney forms, but it's too small, fewer functional units, fewer lobes. And dysgenesis, that's where the development is just abnormal, disorganized tissue instead of proper kidney structure.
And when these developmental issues are severe, particularly with that lack of amniotic fluid you mentioned, there's a specific syndrome.
Yes, Potter syndrome. It's really a consequence of that uterine compression because there isn't enough fluid. You see characteristic features, eyes set wide apart, low set ears, a sort of beak-like nose. It's a direct physical result of the kidney failure impacting the fetal environment.
A very clear link between the organ and the overall physical outcome. Okay, moving from development to inherited conditions.
Right.
Cystic diseases.
Right. These are single gene disorders. The big one is autosomal dominant polycystic kidney disease, ADPKD. This isn't some rare condition. It's actually the fourth leading cause of end-stage renal disease requiring dialysis for transplant. It's a major player.
We hear cysts a lot. What makes these ADPKD cysts so bad? They sound different from simple cysts.
Oh, they are. It's about the sheer number and their destructiveness. We're talking thousands of large, fluid-filled cysts developing from practically every part of the nephron. They just keep expanding over years and years, slowly crushing the normal kidney tissue. It's usually linked to mutations in genes like PKD1 or PKD2.
And it doesn't just stop at the kidneys, does it? There are other major risks.
Exactly. That's the crucial part. Patients get pain from the enlarging cysts. They often develop hypertension because the cysts can mess with the renin-angiotensin system. But the really, really critical thing to flag is the extrarenal risk. About 10% of people with ADPKD also have intracranial aneurysms, brain aneurysms.
Wow, that's huge.
It is. The risk of a brain bleed, a subarachnoid hemorrhage, is significant and drives how we monitor and manage these patients. It's not just about kidney function.
Okay, so ADPKD is the dominant later onset form. Is there another type?
Yes, autosomal recessive polycystic kidney disease, ARPKD. This one's rare but very serious, usually presenting in infants. Here, it's more about cystic dilation of the collecting tubules. The kidneys can become absolutely massive, so large, in fact, that they restrict lung development in utero. That pulmonary hypoplasia is often the biggest factor in the poor prognosis for these babies.
Such different manifestations from similar sounding names. Okay, we've covered development and inheritance. What about just straightforward blockages, obstruction?
Right, physical obstructions to urine flow. This could be anything from a birth defect, like a narrowed ureter, to an enlarged prostate in older men or tumors. But probably the most common cause we see is kidney stones, urinary calculi.
And what's the main problem when urine flow is blocked? What damage does it cause?
Two main things, both bad. First, urine sits-still stasis. And stagnant urine is perfect for bacteria to grow, leading to infections, and also for crystals to clump together, forming stones. Second, the pressure backs up. This causes the collecting system, the renal, pelvis, and calyces, to dilate, to swell with urine. We call that hydronephrosis.
Hydronephrosis. Okay.
But if that pressure continues, it eventually damages and destroys the actual kidney tissue through atrophy. It just wastes away.
So that dilation is a key sign. And if you see it in both kidneys, bilateral hydronephrosis, what does that tell you?
It tells you the blockage has to be low down in the urinary tract, somewhere below where the ureters enter the bladder. It has to be affecting outflow from both kidneys simultaneously. Think bladder outlet obstruction, like BPH, or maybe something in the urethra.
Got it. Okay, let's talk stones, kidney stones. What needs to happen for one to form?
It's usually a combination of three things. First, your urine has to be supersaturated with the stuff the stone is made of: calcium, oxalate, uric acid, whatever. Too much solute for the solvent. Second, you need a starting point, a nidus, like a tiny seed crystal or some debris for other crystals to latch onto and grow. And third, there's often a deficiency in natural inhibitors. Our urine normally contains substances like magnesium and citrate that help prevent crystals from forming or sticking together if you don't have enough of those.
They're more likely to form a stone.
Right.
And there are different kinds. You mentioned composition is key.
Absolutely crucial. Four main types. The vast majority, maybe 75–80%, are calcium stones, usually calcium oxalate or calcium phosphate. They tend to be hard and show up well on x-rays.
Okay, calcium is most common. What's next?
Magnesium ammonium phosphate stones, also called struvite stones. These are interesting. They only form in alkaline urine. And that alkaline urine is almost always caused by a specific type of UTI, bacteria like Proteus, that produce an enzyme called urease, which jacks up the urine pH. Struvite stones can get really big, sometimes filling the whole collecting system. Those are the classic staghorn calculi.
Staghorn, because they look like antlers filling the space. Okay, type 3.
Uric acid stones. These are linked to high levels of uric acid in the blood, so you see them often in people with gout. They like to form an acidic urine. And here's a key clinical point. Unlike calcium stones, uric acid stones are typically radiolucent. They don't show up on a standard x-ray. You need CT or ultrasound to see them.
Good distinction. And the last type?
Cystine stones. These are pretty rare and are caused by a genetic defect in how the kidney tubules handle the amino acid cysteine.
Okay, 4 types. And clinically, what's the main symptom? Pain, right?
Oh yeah, excruciating pain, often. We distinguish between 2 types. There's renal colic, that's the classic symptom, sudden, incredibly severe wave-like pain in the flank that often radiates down towards the groin or testis labia. That usually means a small stone, like 1 to 5 millimeters, is on the move, stretching and irritating the ureter.
Ouch. And the other type of pain?
Non-colicky pain. This is more of a dull, deep, persistent ache in the flank or back. It's usually caused by larger stones that aren't really moving, but are sitting in the kidney's collecting system, distending the renal, pelvis, or calyces. Less traumatic, maybe, but still significant.
So the type of pain tells you something about what the stone might be doing in treatment. It's not just about getting the stone out.
Exactly. Removing the stone, whether with shockwaves, lithotripsy, or surgery, is the immediate fix. But the long game is prevention. And that hinges entirely on finding out what type of stone it was, analyzing its composition, and then addressing the underlying factors. Maybe it's diet changes, increasing fluid intake, maybe medications to change the urine pH or reduce crystal formation.
Makes sense. Tailor the prevention to the type of stone.
Okay, let's shift gears to infections, UTIs.
Urinary tract infections, very common, as we said. Most uncomplicated ones, especially in women, are caused by E. coli bacteria that come from the gut. The severity can range from just bacteria in the urine without symptoms, asymptomatic bacteriuria, all the way up to a serious kidney infection, pyelonephritis.
And our bodies have ways to fight this off, right? Defenses.
Yes, they do. The most basic is just the act of voiding the washout phenomenon. Urine flow physically flushes bacteria out. Plus, the bladder lining itself has protective mechanisms. There's secretory IgA antibody in the mucus, and in men, prostatic secretions have antimicrobial properties. Normal vaginal flora in women also helps. But the bacteria fight back. How does E. coli manage to cause infection despite these defenses?
They have virulence factors. Your pathogenic E. coli, or UPEC, have these specialized hair-like appendages called pili, or fimbriae. These act like grappling hooks, allowing the bacteria to stick firmly to the cells lining the urinary tract so they don't get washed away. And there's a specific type P. poli, that's strongly linked with the ability to cause pyelonephritis, the kidney infection. They seem to help the bacteria resist being engulfed by immune cells, too.
So sticky bacteria. What else increases risk?
Well, obstruction, like we just talked about, stagnant urine is a great place for bacteria to multiply, and reflux. There's urethrovesical reflux, where urine flows back into the urethra during voiding, potentially dragging bacteria back in. More seriously, especially in kids, there's vesicurital reflux, VUR, where urine is forced backward up the ureters toward the kidneys during bladder contraction. That's a major pathway for kidney infections.
Okay, obstruction and reflux. What about in the hospital setting? Catheters.
Huge issue. Catheter-associated UTIs are the most common type of hospital-acquired infection, especially gram-negative ones. The problem is biofilm. Bacteria love to stick to the catheter surface and create this slimy protective layer around themselves. This biofilm shields them from the body's immune cells and makes it really hard for antibiotics to penetrate. That's why catheter infections are so tough to treat.
Biofilm, right. Clinically, how do UTIs present differently depending on location, lower versus upper?
A lower UTI, like cystitis, bladder infection, typically causes local irritation symptoms, needing to pee frequency, feeling like you have to go right now, urgency, and pain or burning during urination, dysuria, maybe some lower abdominal discomfort. An upper UTI, acute pyelonephritis, kidney infection, is usually much more systemic. You often see an abrupt onset with chills, high fever, and the key sign, costovertebral angle tenderness, basically, significant pain in the flank when you tap gently over the kidney area.
That CVA tenderness is a big clue for pyelonephritis. But you mentioned older adults might be different.
Yeah, it's tricky. In older adults, especially those who are frail or have other conditions, the classic UTI symptoms might be absent. Instead, a severe UTI might present as confusion, a sudden change in mental status, unexplained fatigue, loss of appetite, or even just new incontinence. You have to have a high index of suspicion.
Good point. Diagnosis usually involves a urine culture.
Yes, the gold standard is a urine culture. Typically, we look for a count of 100,000 colony-forming units per milliliter, CFUML, to define a significant infection, though lower counts can sometimes be relevant. There are also rapid screening tests, like urine dipsticks that check for nitrite, a byproduct of some bacteria, and leukocyte esterase, an enzyme from white blood cells. They're helpful, but not definitive. And interestingly, there's actually decent evidence, like from meta-analyses, supporting cranberry products, juice, or supplements for reducing recurrent UTIs in some populations. Seems they might interfere with that bacterial adherence we talked about.
The cranberry connection is real. Okay, let's move deeper into the kidney, to the filtration units themselves, the glomeruli.
Right, the glomeruli. These tiny, intricate capillary tufts are where filtration begins. The glomerular membrane, made of endothelial cells, the basement membrane, and those specialized epithelial cells called podocytes, is designed to be selectively permeable. It lets water and small solutes pass through easily, but normally blocks large molecules like plasma proteins and, of course, blood cells.
And when that filter gets inflamed?
That's glomerulonephritis, inflammation of the glomerular structures. And it's a huge deal globally, the second leading cause of kidney failure worldwide. Most cases are caused by immune mechanisms. There are two main patterns of injury we see. First, antibodies can form that directly attack antigens that are part of the glomerulus itself. This gives a linear pattern when pathologists stain the tissue. Second, and actually more common, is when antigen-antibody complexes that formed elsewhere in the circulation get trapped in the glomerular filter. This causes inflammation and damage, giving a granular pattern on staining.
So immune attack, either direct or via trapped complexes. How does this inflammation show up clinically? What syndromes do we see?
Broadly, we categorize the clinical presentations. The first major one is acute nephritic syndrome. Think inflammation, proliferation of cells within the glomerulus. The hallmarks here are hematuria blood in the urine, often described as looking like cola or tea because the red cells get degraded as they pass through. You also see a decrease in the glomerular filtration rate, GFR, meaning the kidneys aren't filtering as well, which leads to oliguria, low urine output, edema, swelling, and hypertension, high blood pressure. The classic textbook example is acute post-infectious glomerulonephritis, which can happen a couple of weeks after a strep throat infection. Luckily, the prognosis for that is generally pretty good, especially in kids.
Okay, so nephritic is inflammation, blood, decreased GFR, swelling, hypertension. What's the other major syndrome?
Nephrotic syndrome. This one is all about damage leading to massively increased permeability of the glomerular membrane. The filter becomes incredibly leaky, specifically to proteins. The defining feature is massive proteinuria, losing more than 3.5 grams of protein in the urine per day. That's a lot.
Wow, 3.5 grams. What does that lead to?
That massive protein loss causes the classic features of nephrotic syndrome. Because you're losing so much albumin, the main protein in blood, you get hypoalbuminemia, Low albumin levels in the blood, typically below 3 GDL. Low albumin reduces the osmotic pressure holding fluid in the blood vessels, so fluid leaks out into the tissues, causing generalized edema swelling everywhere. And for reasons that are a bit complex, you also typically see hyperlipidemia, high levels of cholesterol and triglycerides in the blood.
So massive protein loss, low albumin, edema, and high lipids. Those are the core features. But you mentioned earlier there are other serious risks with losing all that protein.
Absolutely critical risks. When you lose protein indiscriminately, you don't just lose albumin, you also lose vital immunoglobulins antibodies. So patients become incredibly vulnerable to infections. That's a huge clinical concern. And perhaps even more dangerous, you lose natural anticoagulant proteins like antithrombin III. Losing those tips the balance towards clot formation. Patients with nephrotic syndrome are in a hypercoagulable state, meaning they have a very high risk of developing dangerous blood clots like deep vein thrombosis, DVT, or pulmonary embolism, AE.
So infection and thrombosis risk are major complications beyond the obvious swelling. Got it. Now, these glomerular problems don't just happen on their own, right? They can be part of larger systemic diseases.
Definitely. Several systemic diseases commonly affect the glomeruli. The number one cause of kidney failure needing dialysis or transplant in the U.S. is diabetic glomerulosclerosis, basically damage from diabetes. The high blood sugar leads to changes in the glomerulus, particularly widespread thickening of the glomerular basement membrane, eventually leading to scarring and loss of function. And the earliest sign we can detect, often years before GFR drops, is microalbuminuria, small amounts of albumin leaking into the urine between 30 and 300 milligrams per day. Catching it at this stage is key.
Microalbuminuria, the canary in the coal mine for diabetic kidney disease. What other systemic diseases are big players?
Systemic lupus erythematosus, or SLE. Lupus nephritis is common. Here, those circulating immune complexes we talked about, characteristic of lupus, get deposited in the glomerular walls, causing inflammation and damage. Treatment usually involves suppressing the immune system. And then there's damage from long-term high blood pressure. Hypertensive glomerular disease, sometimes called benign nephrosclerosis. This involves hardening and narrowing of the small renal arterioles, leading to ischemia and scarring in the glomeruli. The kidneys often become smaller than normal.
And who's most at risk for that hypertensive damage progressing to failure?
The book specifically points out that the risk of progressing to end-stage renal disease from hypertensive nephrosclerosis is significantly higher in individuals of African descent, people with very severe or poorly controlled blood pressure, and those who also have diabetes on top of hypertension.
Important risk factors to keep in mind. Okay, we've covered the filters. Let's move to the final sections. The tubules and the surrounding tissue, the interstitium, and then tumors.
Right. Tubulointerstitial disorders. Problems here affect the reabsorption and secretion functions of the kidney tubules. So early signs often relate to those functions failing. For instance, an inability to concentrate the urine properly, leading to excessive urination, polyuria, especially at night, nocturia, or problems with acid-base balance, leading to metabolic acidosis.
Let's focus on that acidosis. Renal tubular acidosis, RTA.
Yes, RTA is a classic example of a tubular defect causing a systemic problem. It means the kidneys can't properly handle acid excretion, leading to metabolic acidosis. There are different types. Proximal RTA involves a defect in the proximal tubule's ability to reabsorb bicarbonate. Remember, about 85% of filtered bicarbonate gets reabsorbed there. If that fails, you waste bicarb in the urine. This type is often seen as part of Fanconi syndrome, which is a more generalized dysfunction of the proximal tubule.
Okay, so proximal is about losing base, bicarbonate. What about distal?
Distal RTA is a defect in the distal tubule's ability to secrete hydrogen ions, acid, into the urine. So the kidney fails to make the urine acidic enough. This leads to chronic systemic acidosis. Because the body has to buffer this acid somehow, it often starts pulling calcium salts from bones, which can lead to bone disease over time. These patients also tend to form calcium phosphate kidney stones because the urine is inappropriately alkaline and high in calcium. They also often have low potassium levels, hypokalemia.
Different mechanisms, different consequences. What about external things damaging the tubules, like drugs?
Absolutely. Drug-related nephropathies are common because the kidneys get such high blood flow, about 25% of cardiac output, exposing them to high concentrations of drugs and toxins circulating in the blood. Drugs can damage the kidneys in several ways. Some can directly reduce blood flow to the kidney, think NSAIDs like ibuprofen, or the contrast dye used for imaging studies. Others can actually crystallize within the tubules and obstruct flow. Classic example is some older sulfa antibiotics. And some drugs can trigger allergic-type reactions in the kidney interstitium, causing inflammation called acute tubulointerstitial nephritis. We often see this with certain antibiotics.
So always have to consider medications as a potential cause of kidney injury. Okay, finally, let's touch on kidney cancers.
Two main ones highlighted in the chapter. In children, the big one is Wilm's tumor, also called nephroblastoma. It's the most common solid abdominal tumor in young kids, usually peaking between ages 3 and 5. The classic presentation is actually a large abdominal mass that the parent discovers, often while bathing the child. Importantly, it's usually asymptomatic initially. The good news is that with modern treatment surgery, chemotherapy, sometimes radiation, the prognosis is excellent, around a 90% 5-year survival rate.
That's great progress. What about kidney cancer in adults?
That's typically renal cell carcinoma, or RCC. This usually occurs in older adults, peaking in the 60s and 70s. Major risk factors are heavy smoking and obesity. Like Wilm's tumor, RCC is often silent in the early stages. The classic triad of symptoms, hematuria, blood in urine, flank pain, and a palpable abdominal mass usually indicates pretty advanced disease. Interestingly, though, more and more RCCs are being found incidentally these days just because we do so much abdominal imaging, like CT or ultrasound for other reasons. They get picked up by chance when they're smaller and potentially more curable.
An incidental finding interesting. Okay, wow, we've really covered a lot of ground.
We really have, from both defects like agenesis and the implications of oligohydramnios leading to Potter syndrome, inherited diseases like ADPKD with those dangerous aneurysms, then obstructions, the different types of kidney stones and their specific pains, the fight against UTIs, how E. coli uses pili, the problem of biofilms, and then diving into the glomerulus, distinguishing the inflammatory and nephritic syndrome from the leaky nephrotic syndrome with its protein loss and clot risk, and finally touching on tubular dysfunction like RTA, drug damage, and the key kidney cancers, Wilms, and RCC.
It's quite the journey through renal pathology. And this really brings us to a final thought, maybe a question for you, the learner, listening to this. We've seen how different underlying mechanisms, genetic defects, blockages, infections, immune attacks, toxic exposures, cancers can all potentially present with similar signs, like, say, blood in the urine, hematuria. So the question is, how does understanding these distinct pathophysiological processes actually change how you approach a patient? How does knowing whether hematuria might be from a tiny moving stone versus glomerular inflammation versus a tumor fundamentally alter your thinking, your differential diagnosis, and ultimately your plan for assessment and care?
That's really the core of applying this knowledge, isn't it? Linking the mechanism to the management. Keep pondering that as you integrate this information.
Exactly. Thank you so much for joining us for this deep dive into renal function disorders based on Porth's pathophysiology. We hope this helps clarify these complex topics. Until next time, keep exploring the details.